Bismillahirrahmanirrahim. Today we are going to discuss how to perform the PVD, and we are honored to have our dearest panelist, Professor Dr. Ehab, Professor Dr. Hany Hamza, Professor Dr. Hassan Mortada, Professor Dr. Mohammad Moghazi, and Professor Dr. Mostafa Nabih. So our agenda today is to discuss how to induce a PVD and how to safely and efficiently propagate the wave of the PVD. Do we need a special modification based on the pathologies that we are dealing with? What are the signs of successful PVD, and what are the helpful tools that we can do it during our surgery? So first to start, Dr. Mustafa, where do you prefer to start your PVD? Isn't the mic, please?
I usually start midway between or at the temporal edge of the optic nerve head. If it is successful, okay. If not, I try other points around the optic nerve head.
Okay, Dr. Hany, which one to follow, the footprint over the retina or the edge that is incarcerated in the cutter that you are moving? So what you are looking for to know that you are propagating the PVD?
Well, I'm looking at the propagating wave, which is more important because sometimes you get a firm adhesion in the way and then you have to stop. So
Okay.
this is safe to look at the propagating wave and to see where it has stopped exactly, which should be the posterior border of the vitreous space.
Okay, but I mean that sometimes there is a discrepancy between the wave that is going on the retina and what you have in the port of the cutter. So which one that you feel that you are moving and propagating the wave? The one on the retina, the enlarging one over the retina, or the one that you have in the cutter?
The enlarging one over
Over
the
the
retina,
retina.
and then I restain again, probably with triamcinolone, to check if there is vitreous cases again.
Dr. Hassan, do you propagate the wave at once or gradually at different quadrants? So you start some part at the nasal part and then you propagate it superiorly.
صوت بيقطع بس. السؤال الثاني كده
I mean, do you propagate the wave all at once, or you try to do it gradually so you can look where the wave is propagating?
First, I differ from where to begin, usually on the nasal side. I do not like to start on the temporal side or between the disc and the macula. I start on the nasal side and then extend the wave. And as I proceed to the periphery, I like to divide the posterior hyaloid, the detached posterior hyaloid, so as not to transmit traction to other parts of the retina not well seen during the PVD. And I follow the spreading wave. Of course, the use of the 25 gauge system with the beveled end facilitates the engagement of the posterior hyaloid.
Okay, so Dr. Ehab, do you feel it that we induced the wave correctly, and now we have raised all the PVD, and we don't need to ensure that there is still some remnants and we have to stain? Or do you stain most of the cases?
Usually I don't stain most of the cases. It's just in high risk patients that I like diabetics, like myopia, that's the one that I restain. But in most of the cases I don't stain initially.
Okay, so Dr. Moghazi, at this step, do you feel that we have done the job and we start to peel the eye lamp, or do you ensure some vitreous cortical remnant at the periphery?
For sure, there is some vitreous cortical remnants at the periphery, but let me add to the first question. It's, I usually start also nasally, like Dr. Hassan mentioned, but the thing is, I always stop and regrasp, because if you continue going through the wave and you don't cut, what happens is that sometimes the edge that you're grasping, the vitreous space, the cortex with, is entangled within the probe, and you might be inducing traction in the periphery. So once I see a wave, I just stop, cut, regrasp, stop, cut, and regrasp to ensure that I'm not pulling at the periphery. The other thing is, I like Dr. Ehab said, I don't usually use triamcinolone in all cases. I think when you have PVD with a Y string, I think you have it all. But sometimes, especially in a pediatric age group, I really can't induce a PVD, and sometimes I need to use a triamcinolone, but not in all cases.
I just have a minor comment. Although starting at the nasal side is safe and safer, but there is also an advantage of starting on the temporal side, catching the premacular bursa, which is sometimes easier to detach the posterior hyaloid.
One just quick comment. The easiest point to start actually is superior. It's not nasal or temporal, because usually that's how the PVD happens in normal life. You start having separation from vitreous superior, then it goes on. So the easiest point is the anatomical part is the gross superior. Then you can, of course, continue with the nasal or the temporal. But the first initial easiest step is the superior.
Dr. Hany, sometimes we may face that we have a media opacity like these cases. So we have a dense vitreous hemorrhage, asteroid hyalosis, membranes with cells in vitritis and uveitis. But sometimes we have this clear media. Do you prefer to have some core vitrectomy that may facilitate the PVD induction, whatever over the desk or temporal side? Do you believe that doing some core vitrectomy may help?
Yes, I do some core vitrectomy, but not too much. Otherwise, you can lose the grasp of detaching
Yes.
the posterior hyaloid.
Because in some practices they advise to have the whole vitreous, so you can take a big bunch at the tip of the cutter, so you can easily remove it over the discs. So Dr. Hassan, which one do you prefer, or do you feel that it's much more efficient during the initiation of the wave?
I do core vitrectomy. I remove the central part of the vitreous, and I leave sufficient amount of the vitreous in front of the posterior, around the optic disc, so as to have a good grip of the vitreous. So I do not do vitrectomy till the optic disc. For restaining, usually I do after inducing PVD, I inject a small amount of triamcinolone to make sure that there is no islands of cortical vitreous still adherent to the underlying retina. The important thing also is, while peeling to the periphery, you have to use a wide-angle viewing system. You decrease the magnification, so as I have to have a wider view. And because most of the breaks that may occur usually occur at the periphery.
We will discuss the propagation and the tears later. Dr. Ehab, did you would like to add anything?
Just a quick comment. The cases that you show about debulking the vitreous when you have hemorrhage, I usually like to keep the vitreous intact until I aspirate the hemorrhage
We will have
to
this
avoid
one
the
analysis for you. So Dr. Hassan, sometimes we face this scenario that we start the PVD at the disc. But we cannot initiate, despite that we have frequent trials and we increase the vacuum. So when we cannot initiate it over the disc, what are your clues that can help that tackle this point?
Only in these cases, I inject triamcinolone to start with. Because in other cases, I do not inject triamcinolone at the beginning. But in these cases, I inject a small amount of triamcinolone because in these cases, the posterior hyaloid is like a sheet strongly adherent to the underlying
So
retina.
with adding the triamcinolone, just to highlight, Dr. Hassan, with adding the triamcinolone, just to highlight where is the PVD, or it will change the texture of the vitreous itself?
No, it will reveal that the posterior hyaloid is there, and it start to manage by other techniques, maybe by the probe, also by vacuum, but I may use some scraping instruments.
This is the clue, as Dr. Hany was telling us, that sometimes we can start the PVD at the temporal part, because we may find this cluster over the ciliary nerve, whether nasal or temporal. And my question here, Dr. Ehab, would you do it as a retrograde?
The problem is with all thinking that you have to initially start at the nerve. The anatomy is different from one patient to another. Sometimes you have detachment of the PVD, like in this patient, the stage 4 macular hole will be detached over the macula but attached to the disc.
Yes.
So initially trying to go for the disc, you make things harder. If you just start cutting the hyaloid around the macular area, the dissection of the fluid will separate the disc and the rest of the area. So from one patient, there is anatomical variation where the detachment normally happens. You might have a detached hyaloid over the macula. It might be somewhere in the periphery. So as Dr. Hassan just said, that when you put the triamcinolone, you can detect where the initial PVD happened.
Dr. Hassan, please.
why we should start at the optic disc whenever possible, because this is the strongest part of the retina.
Sure.
If we start at the periphery, this is the weakest part of the retina. And if you pull on the peripheral part of the retina, you may induce a peripheral break.
Okay.
So if it is possible to start at the optic disc, whether superior, nasal, but avoid starting at the periphery.
Okay. Dr. Mostafa, we will shift to the VMT. Do we need a special modification for our technique, or do you have a safe way to induce the PVD, and especially in VMT cases?
In vitreomacular traction, you can be lulled by the impression that you can easily detach the already curved posterior hyaloid. This is not true. Usually there is a sheet of posterior hyaloid on the retina in those cases. Maximizing suction, changing the site of starting of induction of PVD, and maybe scraping with triamcinolone staining,
So
maybe hydrodissection.
my question is, sometimes if we cannot progress it over the nasal part, so we can do it over the temporal part, over the macula. So in VMT cases, if we cannot initiate it in this case, can we try to move over the macula to start to detach it over the macula? Or you try to avoid the premacular vitreous at this step to avoid any traction or de-roofing of a system?
Actually, we can go around the macula,
Yes.
not directly over the macula.
Okay. So if we are propagating this wave and we reach it that we safely still securing the macula, but at this time it was debulked or detached from the macula. So we have a good PVD and we progress the wave. Do you prefer to do like an eye lamp flap to secure any iatrogenic break later on? Or I mean iatrogenic full thickness macular hole? Dr. Hany?
I mean, you had a safe detachment of the posterior hyaloid, and you have a macular hole.
No, there is no macular hole at this step,
I wouldn't do an eye lamp flap. No.
despite that it was detached with the PVD, right?
Which,
In this step,
yes,
it was detached as Dr. Mostafa was
The ILM?
trying. No, the PVD was pulling over the fovea,
yes,
and it was detached right while we are progressing the wave.
okay.
So at this step, do you have the fear that it may induce a full thickness macular hole and you like to add an eye lamp flap?
If I can see a macular hole,
No, there is no macular hole.
I wouldn't do a flap.
Okay. So the second one, Dr.
Can I
Ehab-
add, can I add something regarding
Sure.
the vitreomacular traction? I think the preoperative OCT is very important in those cases. If you
as in
have
this case?
okay, I'm just commenting about if you're detaching the posterior
The
hyaloid.
next case for you, Dr. Moghazi, the one after this. Dr. Ehab, this case is a vitreomacular traction with this central cyst and dense epiretinal membrane. So what are your advice or your modified technique in such case?
Well, you just showed it. You go circumcising. So in these patients, I put triamcinolone. This is very important to see the dynamics of the hyaloid while you're cutting all around. I always leave a stump coming out with the least traction on that stump till the end. So I like to see what I'm doing, especially in the macular area, then circumcise all around to have a stump of vitreous coming out till it detaches.
So we are trying to separate the premacular vitreous from the whole vitreous, and then we will deal with this area.
Exactly. I don't do a PVD then. If you do a PVD, then you have a high risk of creating a break.
Okay.
Of course, judging by the preoperative OCT gives you a clue. If there is epiretinal membrane, you have a higher risk than if there is no epiretinal membrane.
Dr. Hassan, please.
I do not like to inject triamcinolone in vitreomacular traction because it hides the behavior of the underlying retina.
Early or late? Early or late? You don't inject triamcinolone at all?
No,
or
at the beginning.
At the beginning, yes.
At the beginning. And again, I start on the nasal side and I proceed cautiously to the temporal side, keeping an eye on the behavior of the macula. Sometimes you see that there is traction on the macula. In this case, you have to circumcise, as Dr. Ehab said, circumcise the posterior hyaloid around the fovea, especially on the nasal side, and then you try to circumcise on the temporal side, and there is no need to detach over the fovea.
Okay. In this case, do we have to remove these remnants or vitreous, friable vitreous over the fovea? Do you need it, or just separating it's enough?
Just separating it. There is no need to detach the stump attached to the fovea. I mean,
And no need to do an ILM in this case.
no, I do an ILM.
So you will do this just to remove the vitreous cortical remnants?
Yes, I will. In this case, I would do an ILM peeling without the flap.
Yes, to remove the vitreous, right?
Yes, to make sure that I have removed
The whole
all the
vitreous.
traction.
Okay. So the next case is Dr. Moghazi. This is a very complicated case with a hemorrhagic PVD, a senile retinoschisis inferior temporal, and a very broad vitreomacular traction with an ERM that is pulling over the superior arcade. As we can see, this is a detached superior arcade because of the tenting vitreous. So how would you proceed with such a complicated case?
Well, again, I will start at the disc. PVD, I'll start at the disc. In those cases, I'd like to use triamcinolone because early, yes, because it would show me exactly where the tenting is. I mean, you see now there is no enough triamcinolone. So
no triamcinolone yet.
Yes, so at areas of traction, not down there, but up here, like you said, you will not be able to really see where the vitreous is tenting over the retina.
And over this area, it was detached because there is an attachment to the retinal membrane, as it was shown in the OCT.
Yes, exactly. So I would like, in those cases, to use the triamcinolone early, and I usually stop where the vitreous is tenting over the retina, and I circumcise around that, and maybe at the end I will trim it. But at the beginning, I don't want to create any new breaks.
So we tried to trim it, but we couldn't, and we shifted to this step. Is it correct?
Yes, I would do the same thing. If you don't find it safe to trim it early, you can do this and then go. I just can leave a little bit of a stump at the area of traction, okay? And it won't affect anything. But it's not necessarily that you remove it completely.
And what is this unstainable layer that we are peeling now?
This is an epimacular membrane. So it's a negative staining.
It's a membrane or a vitreous cortical remnants?
I don't think it's I think it is just a membrane under the vitreous, and it wasn't stained with the brilliant blue, but it can be stained with the triamcinolone sometimes not. But if you can see the consistency of it, it's not vitreous.
Okay, so after we remove this part, we still have under this layer, we will have another unstainable layer that is shredding. And it looks.
You can have several layers of an epimacular membrane. By the way.
So it's this layer. It's an epiretinal membrane. The one is removing now. Is it a membrane or is it a remnants of the cortical?
Could be a membrane mixed with some of the cortical vitreous, but it's really hard to judge from the video. But I think the consistency of the posterior hyaloid is different from the consistency of an epimacular membrane.
Sure.
They behave differently under the forceps. The idea is you can trim both together. You can trim both the epimacular membrane and the ILM, and you stop where, if you have traction like this at the fovea and you're afraid to deroof the cyst, you can stop at the fovea. And I usually use very low suction, very high cutting, just to trim it, just to leave a
sparing.
Maybe minimal fovea sparing. I just leave a very small stump there, and I don't insist on removing it completely.
Dr. Hassan, please.
When you have an epimacular membrane and you want to remove the internal limiting membrane as well, when you inject the dye, the staining of the posterior pole is not homogeneous. Sometimes areas are well stained, and there are other areas that are not stained or less stained. When this is the case, you know that there is an epimacular membrane and there is an underlying internal limiting membrane. So you remove the epimacular membrane and then you restain if you want to remove the remnant of the internal limiting membrane. So this is a very important sign, whether the staining is homogeneous or it is a heterogeneous staining. And this is a clue if there is an epimacular membrane. And also there is paravascular. The staining with the brilliant blue in the paravascular areas is less than in the other parts of the retina.
Sure. So, Dr. Ehab, we will move to this topic, which is optic disc pit with an outer retinal layers hole and the impending full thickness macular hole. So, do you commonly see this stump that is emerging from the disc in these cases, and what is the approach in such a case with a large neurosensory detachment?
Well, in these patients, I would do a vitrectomy. But of course, it's shown before by several surgeons that when you cut the stump or when you pull on the stump, you increase the connection or you make the connection between the vitreous cavity and the subretinal space even better.
Worse.
Yeah, and that's why it causes even a higher detachment. But it's part of the surgery. You have to do that. In these patients, you have to be very careful. I won't, of course, remove ILM in such a patient because you can easily deroof the cyst. Whether you put something on the optic nerve or not, usually possible.
No, I mean, the PVD, do you have a special recommendation while doing the PVD to avoid deroofing of this cyst, or you will proceed with the PVD as normal cases?
It depends on how much it's attached, but most of these patients, I would go ahead with normal PVD detachment for these patients. If you leave the hyaloid, then you have a higher risk that it will still not flatten up later on.
We will not leave the hyaloid definitely, but I mean, do you do it like a VMT case? You remove, separate it from the premacular area. You will separate it from the peripheral vitreous, or you will do it in a normal fashion as from the disc and you propagate it in all the quadrants?
The same technique which I use, but I keep an eye while crossing over the macular area. That's the most important part.
So, Dr. Hany, how do you approach in this adherent friable gel in cases of uveitis? This is a case of uveitis. Okay, this is a case of uveitis with a friable adherent gel. So how do you proceed with these cases that it's not a one sheet?
I think in these cases you have to be very cautious in detaching the posterior hyaloid, and it has to be done in steps. And you remove and you stop and you pull and you see, because there are also possibly some areas of retinitis in these cases which may induce retinal breaks. If I want to add one more comment, that I use triamcinolone in these cases. And the use of triamcinolone, actually, in these cases, I diluted 1:6 or 1:8, so that you have a map of the posterior hyaloid and its attachment, and it doesn't hide the underlying retina. If you dilute it so much, you can see through it and you can do it safely.
Dr. Hassan, is it a mandatory to remove the vitreous completely at the first attempt in this case?
If the vitreous is very strongly adherent in these cases, then I would try to remove as much and as safe as possible. And then I trim the vitreous where it is strongly adherent for fear of creating a retinal break.
Dr. Ehab, in cases of endophthalmitis, so how do you approach and when do you stop doing the PVD?
In endophthalmitis, I think the worst thing or the most traumatic part is trying to create a PVD. The retina is totally atrophic, and the more you're going to go for the vitreous, the more that you're going to lose the case and have keratogenic breaks. I usually flush the vitreous as much as possible to the retinal surface and make sure it's interrupted islands. If you leave interrupted islands, there is no problem with that. It's less than creating tears. But the thing is, if you leave it as a continuous sheet, then you are higher risk of creating or creating on PVR. So I try to leave vitreous, if it's necessary, as interrupted islands, flushing it all the way to the retinal surface, but I never pull.
Okay, Dr. Moghazi, is there a difference between these two white lesions in the two cases? The first one is Bahset and the other one is endophthalmitis. So which one you will tackle and the other one you will leave?
I'm sorry, which two parts, which two white cases?
The white lesion now under the cutter in the endophthalmitis case, and the other one in the Bahset in the peripheral, there is a white lesion.
Well, so okay. And in the endophthalmitis case, this is just subhyaloid pus. So
and it may be combined with retinitis.
Could be underlying retinitis. I don't see hemorrhage.
So will you attack this area?
Well, yes. As a continuation of Dr. Ehab's comment, in those cases, a general rule, I don't go after PVD. However, in those areas of pockets of pus which are entrapped under the posterior hyaloid and they are not within the macular area, I go very gently, not with the cutter, but maybe with the hard tip. I try just to create a hole, an opening.
Yes.
This would allow the antibiotics infused to go under or between the hyaloid and the retina. And if I can safely just continue just deroofing over those collection of pus, I would go safely. But if I cannot, I will stop, because this can very easily create breaks. You have to assume that all cases of endophthalmitis, they are associated with retinitis. Of course, the cases where you can find those hemorrhagic infarcts are more liable to induce breaks while dealing with the posterior hyaloid. But I won't chase definitely for a complete PVD in those cases. In the upper, the uveitic, the uveitis part, this could be the byproducts of inflammation again under the vitreous.
And this is a vitreous itself.
Yes, but
Yeah.
there is like
So it's more safer
deposits.
in the Behçet case than the endophthalmitis, right?
Yes, of course. Yeah.
Okay, and do you screen all your cases at the end of the surgery? Do you finalize your surgery with a peripheral screening,
You mean you want to
searching for tears?
Of course. Yeah.
Yes, as in this case in Behçet, that we found these, after clearing all the vitreous, we found these two iatrogenic breaks, I think.
I think it's easily seen during the surgery, because when you're very close to the vitreous base and doing your shaving, I think the areas where the retina is pulled, okay, you have to suspect a break in that area.
Dr. Hassan, when do you perform a PVD in such a case with dropped lens matter? Is it before attacking the lens or after attacking the lens? Can you have the mic, please?
If I'm going to use the phaco-fragmentor and it is a hard lens, then I would do posterior PVD before attempting to deal with the dropped lens matter. But even if it is, I'm going to use the cutter, I would prefer to do a posterior vitreous detachment before attempting to remove the cortical or the dropped nucleus.
Dr. Hany and Dr. Mostafa, please.
Actually, if I can move this piece of nucleus in the presence of an attached posterior hyaloid, I can move it through fluid to the middle of vitreous cavity, and I am using the bare tip of the phaco-fragmentor of the phaco-emulsification. I just do it and leave the layer of posterior hyaloid on the retina till the end, and usually it is the case.
Okay, and if you are going to use a phaco-fragmentome, would you leave the vitreous?
Actually, I use the bare tip of
I
the
know.
phaco-emulsification. I think I don't use the fragmentome actually. The other one is more efficient.
Dr. Hany, please.
I do actually the same. I leave a cushion of vitreous posteriorly, do the phaco-fragmentation, and then do the posterior vitreous detachment in these cases.
So if we are trying to do, Dr. Moghazi, at this step, the PVD, would you add a triamcinolone at the initial step to highlight the vitreous, or you don't need it?
Well, if I'm gonna use a phaco-fragmentome, which I use, I would definitely remove the posterior hyaloid and make sure at the sclerotomy sites and the cannula side there is no vitreous entangle, because you're just using a suction machine. It's not cutting anything. But if I'm gonna just use the cutter, if there is just some fluffy epimacular, cortical material, I wouldn't bother removing the posterior hyaloid, and I wouldn't bother even removing it after removing this cortical material. I have seen cases where you go ahead, you induce the PVD, and you continue the PVD until the periphery, and those patients are actually more liable to induce a break while doing that than just leaving the posterior hyaloid attached. Leaving the posterior hyaloid attached will not harm the retina or not increase the incidence of postoperative.
Would early removal of the vitreous facilitate the removal of these
No,
parts?
no.
You don't have this sense. So if we have the vitreous,
no.
we can easily remove this.
You can still do. But if you're going to use the phaco-fragmentome, of course you have to remove the vitreous.
Okay, Dr. Ehab, please.
Most of these patients that already had phaco and you put an infusion cannula, there will be a PVD, whether you use it or not. But the question is whether you do it in the beginning of the case or at the end.
Yes.
I think you must do it in the beginning, because any ultrasound that you're going to have vacuum cut. So once you have vacuum inside the eye, you'll get some vitreous with the hyaloid entangled in the probe once you don't have nucleus. So the issue of traction transmitted to the rest of the retina is very high if you leave vitreous and try to go. So I treat a dropped nucleus as an intraocular foreign body. With foreign bodies, I remove the vitreous and deal with it.
Dr. Hany and Dr. Hassan, please.
One more comment is that if you can create a fluid cavity by a core vitrectomy in which you can pull this nuclear material inside and then activate the ultrasound, I think you won't exert peripheral traction. But these are different opposing points of view, and both are valid.
Dr. Hassan.
Yes, I think whether you are using the phaco-fragmentor, with which you should remove the vitreous as complete as possible, or you remove it with a probe, you have to remove the posterior hyaloid first, because you are creating
Attraction.
vacuum, high
Yes,
vacuum.
attraction.
Yes, and this vacuum, you cannot control it. Is it applied to the fragments or to the posterior hyaloid? And this traction can be transmitted to the retinal periphery, creating retinal break. So why not to remove the vitreous
Sure.
completely before
Yes.
dealing with the...
So we'll move the next part is rhegmatogenous retinal detachment, and not all cases of rhegmatogenous detachment we have the PVD already done. So sometimes it is attached over the disc, and this is the clue where Dr. Mostafa, can you tell us about your case, please?
This is a case of very highly bullous retinal detachment in a young man. The problem in catching the posterior hyaloid here is that if you apply suction, you can very easily get the retina. So you apply it with the back of the probe facing the retina. Then if you want to continue to the periphery, you have to have counter traction by adding perfluorocarbon fluid to the posterior pole, so you can propagate this more easily and effectively to the periphery.
So sometimes in these cases, Dr. Hassan, you cannot propagate the wave even after or beyond the arcades. So, and you're faced with this hard attachment. So how will you proceed, and do you stain at any part of this step?
This is a myopic eye.
Myopic macular hole, yes.
Yes. You have to do detachment of the posterior hyaloid, and also vitreous cases is expected to be
Yes, sure.
present. So you have to look for other layers of the posterior hyaloid. The location of the ora serrata here is, or the posterior border of the vitreous base is located posteriorly.
And this
So-
layer, is it a vitreous cases or is it a premacular membrane?
No,
as Dr. was?
this is a part of the posterior hyaloid.
Yes, and
This
which,
is not an EP.
and which stain will you use? Is it obvious with the BBG, or at this step you may add triamcinolone?
You can use the blue dye, or you can use the triamcinolone, although I prefer the blue dye in these cases, because it
Yes, much
it
better.
is much better view of the
Again, it's the contrast
yes,
of the
yes.
choroidal atrophy, and would adding the filters of the digital era now would help in this step?
Yes, I would in these cases with some reflection from the back of the eye, I would use the green filter or the yellow filter, because it enhances, it reduces glare, and it enhances the visualization of the tissues.
Okay, so Dr. Hany, would you tell us about your technique in such a complicated case of retinal detachment in stickler babies or children?
Well, this is a child with Stickler syndrome, and you can see that the posterior hyaloid is very firmly attached to the posterior pole. I had to use this bimanual technique to pull these bits and pieces of the posterior hyaloid, and the retina is quite mobile. And the bimanual technique is very useful in these cases, and you can pull, but you can see that it is firmly attached. At the end, I had to remove the ILM to ensure that the posterior hyaloid is completely removed from the posterior pole. I had some bleeding during the peeling, but it's fine. And then I put perfluorocarbon, and I did this ILM peeling. These cases are actually very tough in detaching the posterior hyaloid, Stickler syndrome.
So it's very nice showing. So, Dr. Hassan, please.
Well, in pediatric retinal detachment, you cannot predict the behavior of the posterior hyaloid before going inside the eye. In some cases, but not in the Stickler syndrome, the posterior hyaloid can be detached easily. In others, as Dr. Hany's case, it is strongly adherent. I also go for the bimanual using two forceps, or forceps and the cutter. So another technique is the teasing.
Yes.
You hold the two tissues between the two tooth forceps, and then you
Pull it
tease
apart.
Yes.
Yes.
You pull it up. This will help to detach the posterior hyaloid. However, you will reach a stage where you cannot peel the posterior hyaloid anymore.
Yeah.
And then you have to stop.
stop.
You have
We
to
will
stop
discuss
here.
it in this case. So, Dr. Ehab, in such a case, when we have still against a macular hole detachment, and we initiated the PVD, but we cannot propagate it over the detached retina. So what are your approach in such a step?
In patients, I inject perfluorocarbon. I like to stabilize the retina while removing the hyaloid. Doing it with 2 forceps or a forceps and a spatula is one technique. The central area is my concern. I don't go all the way to the periphery because usually it's very difficult to detach the hyaloid.
At that time?
No, I mean a little bit down the road. But
Okay.
centrally, I will detach it under perfluorocarbon. I flatten the retina, then start detaching it. Gives me a second hand to stabilize the retina while detaching the hyaloid. In very high myopic eyes, you don't have to go all the way to the periphery. You can sometimes shave it, but sometimes you get more damage while trying to pull more. So pulling on these patients is not a good idea. Perfluorocarbon is one good thing to use.
So Dr. Mostafa, can you tell us about your tip in this case?
This is a case of high myopia with retinal detachment. I found difficulty in propagating the posterior hyaloid dissection, so I resorted to what I call hydrodissection of posterior hyaloid. You direct a jet of fluid to the posterior hyaloid, remembering that the fibers of the vitreous are arranged in a radial manner, so this jet of fluid can initiate a hole in the posterior hyaloid, from which fluid goes to the space between the posterior hyaloid and retina, and when it reaches the retina, it is pushed sideways, so the plane can be created between the retina of posterior hyaloid. As you see now, the posterior hyaloid is now a separate sheath from the retina that you can easily remove.
Okay, Dr. Moghazi, if we have this scenario down and we try to do a complete shaving or an oral serrata shaving over the flap tear, so how you will do it? Because it's very adherent at this area. Is it important to remove it first? And how will you remove it if it is important?
No, I usually, a break like this, I de-roof it. I always de-roof it. So I remove just the attached retina, the attached flap of the retina, all together with the traction. So it would make it easier. However, maybe this is a simpler case. You don't have a high retinal detachment, and you can easily do it. But I will still, in that case, if I have removed the whole vitreous until as far as I can go anteriorly, I will go for air at that stage and just continue anteriorly with the vitrectomy under air. This is my technique.
So Dr. Hassan, please.
I'm not against the use of air in shaving the vitreous base, but when you inject air, the vitreous is compressed against the retina.
Mm-hmm. Yes.
So you do not
less
know
mobile, yeah.
It is, yes, and you cannot detect where is the retina and where is the compressed vitreous.
Mm-hmm.
So really, I do not like to inject air while shaving the vitreous base. Sometimes the use of perfluorocarbon is more beneficial, because if you inject perfluorocarbon, the remnant of the vitreous will push the perfluorocarbon away from the retina, and you see it as
convex.
A convex,
yes.
So you can really detect where are the
edge of the vitreous.
The gel is present. Mm-hmm. But when you inject air, the visibility is less, the vitreous gel is compressed,
and the retina is more stiff.
And the retina is, yes. It may decrease the incidence of retinal breaks, but you are not sure that you have debulked the vitreous base. So, although I do not do
under air,
but
it's a present. Dr. Mostafa, please.
Actually, the two methods are not opposing. You have to know both and use both. Sometimes one of them is better. Anyhow, if you are arguing about the visibility of vitreous under air, actually it is more visible than under anything. Yes, as you see in the film, maybe a minute ago. Yes, there are reflections from the vitreous that tell you for sure that there is vitreous, and you can apply suction very little bit and raise this vitreous, so it is going to fall on the retina, and you can easily remove it.
I need your opinion in this case, Dr. Mostafa. This is a case of a macular hole with a vitreoretinopathy, and in the periphery we have these multiple tears that is already present under the anteriorly inserted vitreous. So would you pursue removing all these vitreous and remove the flap of these stairs, or would you leave it in peace and do just a barrage?
Actually, I try to remove as much vitreous as possible, especially in the areas of tears. I repeat the maneuver many times, and there is a trick that I use to know where the vitreous is just by applying diathermy
Yeah.
to where I think it
But
is.
if it is apparent already, would you still insist to remove this vitreous?
Yes, as much as possible, and especially in the upper retina, if I enlarge the breaks or induce even more adjacent breaks, I think removal of vitreous is very important.
Dr. Ehab, please.
Definitely, I would remove the tears, and in this patient, I definitely like to do it under indentation because that counteracts the vitreous that's going to jump in the vitreous cutter. Sometimes you enlarge the breaks while trying to do that. So in the periphery, I always counteract by indenting, deep indentation, and shaping it completely, removing whatever tears is the flaps and the vitreous. I never leave vitreous over
So
flap.
sometimes, Dr. Ehab, in such cases, sometimes when we are propagating the wave, we may face this whitening of the retina. So is it an area that is liable to break up, and I have to be cautious while I am doing the PVD in this area?
Yes, you have to. Because why? Because we have to understand that the vitreous is type 4 collagen and the retinal ILM is type 2 collagen. And when they are attached, actually the vitreous is part of the ILM. So if you're pulling, then you will create breaks.
As this break, as Dr. Ehab was telling us. So Dr. Hany, please, would you add?
I agree with Dr. Mostafa and Ehab to shave as much as possible in these areas, but you have to be cautious because sometimes there is what we call unzipping of the retina. I mean, whenever you get close with the cutter, you induce breaks without touching the retina simply by pulling on the vitreous.
So, Dr. Moghazi, this is a case of a vitreous hemorrhage. So how would you approach such a case with a vitreous and subhyaloid hemorrhage?
Well, you mean talking about PVD again?
Yes.
Okay, so again, I will do a core vitrectomy, and in those cases, after doing an initial core vitrectomy, just to see how the extent of the blood and where it's subhyaloid or just intragel, because sometimes you don't see at the beginning, I would go periphery first. If I have a subhyaloid hemorrhage that's covering the whole retina, I don't see the details, I go to the periphery first, try to create a break in the posterior hyaloid.
You prefer to start outside in?
In case, not this case, but I mean cases where you have a sheet of subhyaloid hemorrhage, okay, so we don't see the underlying retina. So I'm not sure where are the epicenters, I'm not sure if the macula is detached under the hyaloid, so I would just have an opening at the periphery. And once you open the periphery and see the retina, it's safe to progress from there, from outward inwards.
And what your advice about these epicenters? So is it something to take in consideration?
Of course. I mean, usually these are the sites where you can create iatrogenic
So
breaks.
in diabetics, you have to go slowly and detach the PVD in a baby steps.
If you're using only the cutter delamination and segmentation, you stop there, and again you just truncate around or circumcise around until you're able to maybe treat them, maybe cauterize them, and then remove the vitreous over them.
So, Dr. Hany, would you stain at this step, or is it enough for you that, and you are sure that the vitreous is in hand and you can remove it safely with doing this circumcision?
No, I would do staining as well.
At this step?
Yes, even because sometimes you have still remnants of the hyaloid despite this removal in areas that you don't see. I like staining in general, but I'll dilute.
So the next one I will ask about the stain. Dr. Mostafa, please.
Actually, staining is important, but not at this step.
And Dr. Hassan?
I would manage it differently. I would create a hole
in the center?
Posterior, not in the center, but usually there is a PVD somewhere. So you can create a hole in the posterior hyaloid. You remove all the pre-retinal blood so as to have a clear view of the underlying retina, and then you proceed with the all probe vitrectomy or scissor delamination. But I would definitely remove the blood first in order to have a good view of the underlying retina. I may proceed from center to the periphery or from the periphery to the center.
So as Dr. Moghadi was telling, and Dr. Hassan definitely, so if we can approach this case from outside in, This is, I think, is better, so we can achieve to tackle the central membrane and to be in the right plane of the PVD. But sometimes we have this inaccessible hemorrhage. So, Dr. Hany, what is your concern? Is it important first to remove this, and why it is inaccessible, the inferior hemorrhage?
Well, I mean, it shouldn't be inaccessible if the patient is pseudophakic and you do indentation in the periphery. I think you can shave quite well. Why it is inaccessible?
So you will see it again. So now we are, I think, in the right plane, and we achieved to remove all the pre-macular membranes. But still, this peripheral one,
Because the hyaloid is still attached in this area, and the
could it
blood
be?
is trapped.
And would you stain at this step?
I mean, I don't think I need staining at this step now.
So you are confident that you did the PVD, right?
Of course, I mean, I have to remove the proliferations in the posterior.
So
pole.
we removed the
No, I'm not
proliferation.
confident that I removed
So
the PVD.
after we added the triamcinolone as you like, we have the whole posterior cortical vitreous still present,
Yes,
and that
it's attached to the periphery, and that's why you cannot
the
remove
whole,
the blood.
it's the whole,
Yes.
even the macula and the periphery. So, Dr. Hassan, would you add?
The presence of blood in the periphery, and we approach this blood and you try to aspirate this blood, and the blood does not come with the probe, this is a sign
Yes.
that the posterior hyaloid is still adherent. And in all cases of diabetic vitrectomy, you have to stain with triamcinolone because of vitreoschisis, because you may think that you have removed the one layer of the posterior hyaloid, but there is another layer adherent, and it may extend to the periphery, as in this case.
Dr. Ehab, at this step, do you like to continue with the cutter, or do you prefer to have a forceps to elevate this attached vitreous?
I think the cutter is fine. Sometimes the forceps exerts more traction on atrophic laser retina, like in this patient. So I think just doing it very gently with the cutter is one good thing.
And
one more point, just regarding
yes.
the peripheral hemorrhage. Removing the peripheral hemorrhage, I think it's very important, not to the point of the PVD, but these areas need to be lasered, and they're the ischemic areas, so it's part of the problem.
And at this step, is it important to remove the whole cortical vitreous that we found, or is it enough to separate it? So at this step, we approach it, the inferior hemorrhage, because we are in the right plane, as Dr. Hassan was telling us. But do we need to chase the whole vitreous?
To me, as much as possible without damaging the retina. The more you're going to remove the vitreous, the more you're going to treat the ischemic areas, so I have the clear zone, at the same time, but avoiding traction while doing this procedure.
Mustafa, may I add,
Sure.
remind you of a principle that was stated by Zvanovic years ago, that vitrectomy is done when the whole vitreous
Is gone. Yes.
So don't tell me that you are going to leave a part of the vitreous at the periphery. Even in eyes with a macular hole or epimacular membranes, you have to do shaving of the vitreous base.
Dr. Moghazi, these are two kinds of subhyaloid hemorrhage. One is acute in diabetic, and the other one is in an RTA patients after 3 months. Would you approach these cases differently?
Yes, definitely, because in the diabetic patients, you must have an epicenter somewhere under this blood. And if you just try to go like you did on the right side, because here there is no epicenter, you can easily induce more bleeding, you can induce a retinal tear. So I would approach the diabetic premacular hemorrhage very, very cautiously and very slowly. And I would like to, like Dr. Hassan just mentioned, in that specific case, just try to remove as much of the blood to see where I am and where the epicenters are and where the attachments between the vitreous and the retina before proceeding with any pulling on the retina.
Mm-hmm.
This is unlike the other case here, where you can, if it's a Valsalva, for instance, you know there is nothing underneath there, and once you have a grip of the edge of the hyaloid, you can just proceed safely.
So in the second, Dr. Hany, please.
I agree. I mean, you open the hyaloid over the hemorrhage, and what looks as a transparent thin hyaloid, actually after you remove the blood, you will find that it is quite thickened, fibrosed, and has many attachments to the retina. And that's why you have to proceed very cautiously.
In which case?
In the case of subhyaloid hemorrhage.
In the
on left
diabetic?
side.
Both
in
are
diabetics.
subhyaloid. Yes, in the diabetics.
Yes.
So in this case, in the traumatic case, we have an outer ring. Would you chase or try to remove, or is it a folded retina because of the long-standing trapped hemorrhage in this place? So can you see the encircling ring at the macula in the traumatic case with this macro aneurysm that was ruptured before?
Yes, but is it a sub-ILM hemorrhage or a subhyaloid
No,
hemorrhage?
it's definitely a
a
subhyaloid, and
subhyaloid
it is
hemorrhage.
removed. But I'm asking
Yes.
about the peripheral
I would try gently. I mean, if it comes out, it's okay. If it's not, and I'm going to create breaks, no, I will not pull further.
Okay. So, as we have seen how we deal, this case, Dr. Ehab, how would you approach such tractional retinal attachments with a foveal cyst and this subhyaloid hemorrhage? Would you start from the periphery or from the center, and why?
I will debulk the vitreous as much as possible without creating the PVD. Then I will start coming from the periphery to decrease the traction as much as possible centrally.
So can we use this subhyaloid hemorrhage as a cushion, a protective one, to start my PVD because I couldn't initiate it at the disc, or to find the plane to start with over the disc because there is a cyst over the macula that I'm afraid to deal with it? So can we use this technique?
Of course, it's a good idea because having a subhyaloid hemorrhage, that's the least traumatic PVD would happen at that area. So that's the first point to start the PVD in.
So Dr. Hassan, please.
Yes. In such a case, you can start from the periphery or from over the subhyaloid hemorrhage, but you have some proliferation over the optic disc and around the optic disc. So you can start in the center, catching the...
But there is a cyst, there is a tractional cyst over the fovea.
Yes, and then reflecting. I mean, you detach it from the optic disc and then peel it toward the macular area, taking care, keeping an eye on the fovea, and then you may have to circumcise, you may have to, if it is possible to peel, you can peel it. So you can also start from the center, not necessarily from the periphery.
Okay. Mustafa, would you add? Would you like to add?
Yes, we are all talking about the importance of removal of subhyaloid hemorrhage as a first step. Actually, I keep it till the end.
In diabetics?
In diabetics, yes.
This is very
I know exactly where the manifest traction is from the shape of the posterior hyaloid, and the presence of this layer of subhyaloid hemorrhage that is not clotted allows me for much easier removal of blood if it accumulates on the posterior pole. So I leave it till the end and re-inspect the retina. If additional work is going to be done, I do it.
Dr. Moghazi, in tractional retinal detachment with combined rhegmatogenous element, do you prefer to start from outside in or from inside out?
It's really very variable in those cases.
So actually, according to context of the case.
Yeah, whatever works. I mean, if you find the detachment is higher centrally, you go peripherally, and vice versa. So it's really a matter of individualized approach for each case intraoperatively. You cannot really decide from the outside what you do. It's not a one technique for all cases.
So you don't have the feel that if you can approach it from the outside, it's much safer.
It's not safer because you still have you can create breaks at the periphery. This will raise the retina higher and will make your case more complex.
Okay. So Dr. Hassan, your opinion about your approach in tractional combined rhegmatogenous?
Also, it is not necessarily to start from the center to the periphery. It is according to the case. But usually start from the center to the periphery. Usually.
From the center.
Yes. I would start by detaching the stalk, attach it to the optic disc, and then I proceed from the center to the periphery. Because sometimes it is difficult to have a cleavage or a cleavage plane at the periphery. But in the center, if you detach the stalk at the optic disc, you will find the proper plane to proceed from the center to the periphery.
Dr. Mostafa.
This is not the case if you start from...
Actually, in those particular cases, it's very dangerous to attack the periphery because if you apply suction, the retina is mobile and is going to come to your probe very easily. So in those cases, from the center or paracentral area at a site of proliferation as you did. This is an area where most probably you can initiate a plane.
So if we have both approaches are blocked as in the other case, so we cannot approach it from the outside because it is a cemented vitreous as we can see, and if we try to attack it centrally as you said, we can't find the PVD. So how would you approach such a case as Dr. Hassan was telling us? It's maybe both sides that is blocked and we cannot approach to the PVD. How you can approach this case?
Using a sharp dissection in the center with a bent needle.
So you will use a needle.
Yeah, yes, a bent needle like a pick.
Okay. So I was lucky. Dr. Hassan, please.
I will do just as you have done. If this is your video, this is a very
It's
nice.
mine, yes.
Yes. I would start from the center to the periphery. It is always possible to find a cleavage plane when you start from the center to the periphery.
Uh-huh.
But it is much more difficult to find the plane when you start from the periphery to the center.
Okay.
So I think this is the
Approach in such case.
Yes.
So finally, and I'm lucky to reach this point at this step. So these are some a summary for the helpful tools and maneuvers that we can use as staining with triamcinolone, BBG, going in a different site as a retrograde, PVD induction, removing the vitreous or shaving under air, using the subhyaloid hemorrhage as a cushion to start the PVD at, using a sharp needle, using forceps as Dr. Hany showed us, and the technique of buffing using the flute needle as Dr. Mostafa showed us. And it is very important also to know what are the signs of that we have a successful PVD, that we can see the imprint, as Dr. Hany said in the beginning of this lecture. You can just chase the appearance of the retina under the vitreous, or you can see the vice ring that is elevated using the triamcinolone, so you are sure at this step that you remove all the vitreous. Or if you have an intraocular foreign body or a dropped lens matter, when you elevate this PVD, you can see that the lens matter is moving with it. And about the inferior inaccessible hemorrhage, this is a sign of still trapped and residual vitreous cortical remnants. And finally, the accessibility of any hemorrhage and easy removal is a sign of easy and good PVD. And I would like to thank all my panel, and I'm really honored to have you in this session.